Remember, if you're dropped from this session, or if I'm dropped for whatever reason, I can't get back in about more than 5 minutes or so, please just check on your Canvas site a little bit later for the recording of this particular session and its information. So let's go ahead and get started. What I like to do is just to remind ourselves as to why we go through these particular sessions. We have the purpose of this meeting is to review key information that we should have gone over this week at one point, and it gives you an opportunity to ask some live questions. So we'll be doing sort of a summary overview for the material from this week, focusing on therapy. Then at the end, I'll have some announcements and a Q&A for you as well. Just a reminder, what we've done this semester is read the textbook chapters, complete quiz homeworks, view the video lectures, and complete the assigned or associated discussion questions, as well as prepare for our exams. So at this time, as you can see, using your chat feature, please send to me, your host, that you are present at this session. You'll see real soon, I'll put a column on your grade book to give you some extra bonus points for attending these sessions. I'll try to remind us a little bit later if people show up a little bit after we start this presentation to send me a message using the chat system, so I'll have a record of your attendance. Okay, so let's go ahead and get started. And what we're going to be talking about today is going to be chapter 15 on therapy. Okay. So chapter 15, overview. Therapy refers to how mental disorders are treated with the help of the knowledge base of psychology. It takes many forms. So the select topics that we'll be covering during this session today are going to be the following: psychotherapy, the talk therapies, including psychoanalytic, humanistic, behavior, and cognitive. We'll also look at issues in psychotherapy, looking particularly at the evaluation of the effectiveness of psychotherapy. Does it work? And then we'll look at biomedical therapies such as drugs, brain stimulation, and surgery. So let's first talk about the history of mental health treatment. We had a little bit of this discussion during the last session that we talked, which was focused on psychological disorders. So it's some of the same information. So basically what it comes down to, historically speaking, is that when people displayed unusual behaviors and they seemed to be rooted in the mind, these people were often treated in a very harsh manner or locked away and almost all but forgotten. The old ways of getting rid of evil spirits, because at that time, early on, most of the belief system was that these people were acting odd or behaving strangely because they were being possessed, for example, by some sort of evil spirit. And what people would do then, they would try to beat it out of them. Okay, beat the evil spirits out, or bleed the evil spirits out by having blood being drained from their bodies, or having, as we talked about last time as well, having holes drilled in the skull in order to let the evil spirits out so they could escape. So that's the way it was for a long time. And basically, we saw that people were put into very difficult circumstances and treated very, very harshly. But eventually people start to see beyond that and start to think that there are other ways in which people can be treated, okay, that was not going to be so harsh. And this led to reforms in treatment. Here, the key ideas were as follows. Insane people were seen as ill, that they were just simply sick, not being possessed by some evil spirit. It also led to more treatment that was more tender as opposed to being torturous. So tenderness, not torture. And then they were put into hospitals. And remember, the idea about a hospital, that's a place where you go to get better. But when we look at asylums, it was more of a place where you put people who were, quote, crazy, and they were sort of forgotten about. So it's sort of like a storage facility in a sense. And the other key idea when it comes to reforms in treatment was the idea is to treat for some degree of normalcy. And what we mean by that is this: we wanted people to try to live a life that was as normal as they possibly could. And we wanted to get them to that point that they could live a life so that they could be as normal as possible for them. So we see from this the historical view of mental health treatment, very harsh, to something that is more reformed with an idea of trying to treat them in some way. Previously, we talked about the idea of the medical model, and that's what it comes down to. We move away from the evil spirits and those types of ideas as saying that's why people have these mental issues. And we look at it from a point of view is that it is a psychopathology, something that can be treated. Okay, the idea is through talking therapy and of course now by the use of medicines. So what are some of the current forms of therapy? So we'll be talking about psychotherapy, an interactive experience with trained professionals working on understanding and changing behavior, thinking, relationships, and emotions. So how it is that we behave and act, our cognitions, how it is that we think, our relationships, how we interact with one another, and also how we feel. Those are the areas that are of interest in psychotherapy. Then we have biomedical therapy. And here's the use of medications and other procedures acting directly on the body to reduce the symptoms of mental disorder. So at psychotherapy, we are talking about primarily about talking with people, putting them on plans of trying to modify their behavior, for example. And when we talk about biomedical, we're talking about intervening in a way that will change or have some sort of impact on the body. And also, we can combine therapies. There are various forms of psychotherapy. We have an eclectic approach, which uses techniques from various forms of therapy to fit the client's specific problems, strengths, and their preferences. So not everyone is going to be treated the same way. Patients may go out and seek a therapist that has a certain degree of process that they employ that they feel that they prefer. That is a possibility, and it's done quite often. And then we have medications and psychotherapy can be used together and may help each other achieve better reduction in symptoms. Now, from a way back, a long time ago, we mentioned the idea about the difference between a psychologist and a psychiatrist. And one of the key differences is that a psychiatrist has a medical degree, which allows them to prescribe medicines. A psychologist normally does not have that ability. So the idea when it comes to combining therapies, oftentimes we have someone who's going through some form of psychotherapy, but also has some sort of medicine being prescribed to them as well, either by their primary care physician or by a mental health professional like a psychiatrist. So let's look first at psychoanalysis. And psychoanalysis, as we recall, was the idea of Sigmund Freud. And he's usually associated quite a bit with the start of these types of therapies, being a key figure in the founding of many of these ideas. The goal of psychoanalysis is to release the tension of repression and resolving unconscious inner conflicts. Remember, his whole idea was that the unconscious, things which we are not consciously aware of, may be at the root of many of our problems as adults. So he was interested in trying to get to those unconscious conflicts so they can be resolved in some manner. So Sigmund Freud believed that many people have anxiety related to id, ego, superego conflicts, such as repression of sexual wishes. So the idea is this: we may have some sort of desire that we don't even want to acknowledge consciously. And this desire is going to be repressed and maintained in our unconscious, but it still may have some impact on our day-to-day life, how it is that we may be experiencing certain type of anxieties. So remember when we talked about personality and psychological disorders previously, when it comes to Freud, he had this idea of the id, ego and superego. Remember, the id is based on our biological drives. The superego is based on our morality, our societal constraints. And the ego is basically us having to deal with the world of the real, as well as the desires of both our id and our superego. That's our responsibility. So now we're looking at this therapeutic approach of psychoanalysis. He wanted to have certain types of techniques at his hand that he could utilize in order to tap into the unconscious. The techniques of psychoanalysis were, first, free association. This is where the patient speaks freely about their memories, their dreams, and their feelings. And the way psychoanalysis from Freud's perspective worked, he would have the patient sort of lying down on a couch, and he would be sitting behind the patient so the patient could not look at him. This was the idea to sort of allow the patient to open up but not feeling like they're being monitored or being looked at too much. Okay, so they couldn't see the person. They'd be more open to speak freely about certain types of dreams and feelings and things of that nature. The other technique he employed, which was key to many of his ideas, was interpretation. The therapist suggests unconscious meanings and underlying wishes to help the client gain insight and release tension. The basic premise here is that when you shine the light of knowledge, so to speak, and awareness on some sort of issue that you have in your unconscious, once it's been uncovered, that tension, now that it's out, it sort of relieves the pressure and the patient feels better because of it. So those were the techniques that he employed. He also employed hypnosis, putting patients in a heightened state of suggestibility so that they would be able to dive deeper into their unconscious. At one point, Freud did not think that that was as effective a tool as it could be, and therefore he moved on to other techniques such as free association in order to get more at the things going on in the unconscious. Now, this interpretation can be broken down in psychoanalysis. The therapist may see unconscious meaning in the client's resistance, dreams, and transference. The resistance is going to be something like this. The therapist notices times when the patient seems blocked in speaking about certain subjects. So the therapist may bring up something about a sister that the patient had, and then you're trying to get the patient to talk more about the sister, but then the patient avoids it, does everything, starts a new topic. That could be a sign of resistance, something that he does not want to deal with, the patient doesn't want to deal with. And therefore, that may give some sort of idea to the therapist as to what some of the issues may involve going on in their unconscious. Then we have dreams. There may be themes or latent content behind the plot of a patient's dreams. So when you dream, there's the obvious thing that the dream is about. What you did, who was there, what was going on, and all that type of stuff. That would be considered the manifest content of the dream, just an explanation as to what went on during the dream. But what the psychoanalyst would do would be to try to interpret the latent content of the dream. What were the symbols? Why were those individuals in your dream? Why were you doing that behavior in your dream? And trying to uncover the meaning behind it, the unconscious meaning behind the dream. And then the idea of transference. Here, the patient may have reactions toward the therapist that are actually based on feelings towards someone from the past. So as you're bringing up all this stuff from one's past, what happens is you may bring up feelings, okay, that happened in the past too, and you may transfer those feelings because the therapist is there at the moment, transfer those feelings onto that therapist. And that's one of the basic ideas of this notion of transference. So all of these things, as we interpret the meanings behind them, allow the psychoanalyst to uncover things that are going on in the unconscious. Now, it should be noted that with psychoanalysis, its primary focus is going to be on your past. Things that have already happened, things that may have happened long ago. It's very past oriented. Okay, so it's not looking at things in the future or present. It's trying to get to understand the things from your past that may be causing issues in your present. That is what psychoanalysis is doing. I'm going to pause real briefly here to see if there are any questions before I move on to the next topic. You can either break in with the mic here or send me a chat message. I'll take a few sips of water. Okay, seems that there are no questions or comments at this time. Let's keep going. So that is the basic idea of what the psychoanalyst is doing by trying to interpret what's going on with the patient to get more at the unconscious. Now let's talk about psychodynamic therapy. So psychoanalysis is the traditional way in which we think about Freud's techniques of therapy. Now let's look at the psychodynamic therapy. It's derived from the psychoanalytic tradition, so it is based on Freud's ideas, but compared to psychoanalysis, it's somewhat different. And we'll know a little bit more about psychoanalysis by comparing it to psychodynamic therapy. So first of all, compared to psychoanalysis, psychodynamic therapy has fewer sessions per week and takes fewer years. When we talk about psychoanalytic or psychoanalysis, it normally takes a long time for someone to start seeing the results and successful outcomes in that particular approach. That's why normally people who go through psychoanalysis, they're usually going to be people who have the funds and resources to be in such long-term therapy. So they're going to usually be higher on the socioeconomic scale, so to speak. And then also psychodynamic therapy, it has less theory about sex, id, and superego. So it doesn't focus on those things and focus on the sex as much. So it's not going to be focused on the id or the superego. It primarily will focus on the ego. And also, one key difference is in the psychodynamic therapy, the client now faces the therapist. So there's no barrier between the therapist and the client here. So now they can see each other. And also, the focus is on the present in psychodynamic therapy, not just the past. So the therapists help reveal and resolve the dynamics, the forces and changes in the individual. So that's one of the key differences that we see between the psychoanalysis and psychodynamic therapy. So the focus is on improved self-awareness and insight into one's unconscious thoughts and feelings, which may be rooted in past relationships. So you're uncovering things of how you feel and what you thought about your past relationships that may be rooted at that time, but you're really focused on things going on in the present. In addition to insight, therapists suggest changes in patterns of thinking in relating to others. Remember, the key difference here is that the psychodynamic therapist is really focused on how things are going now, focusing on the present, not the past, as we see in psychoanalysis. So one example that they present here is the man who could not feel love because he felt it was not manly. So this is going to be something that would be rooted in this person's past, maybe how he was raised, his interaction with his parents and things of that nature, what decade he was growing up in. So he could not resolve this tension and risk feeling love. And so the idea here is the therapist would shine a light, so to speak, on what in his past relationships may have caused him to think now and learn certain types of patterns of thinking and how to relate to others about manly behaviors. And so the psychodynamic therapist would try to bring this insight and suggest changes to this man's way of thinking now in order to make his life much more pleasant. That is the difference between psychodynamic and psychoanalysis. Now, what happened in the course of time as we see these movements and schools of thought rise and populate and go on? So at one point, we had the behaviorists of B.F. Skinner, John Watson, those individuals, and we had the Freudians and the neo-Freudians. And the key thing here is this: with the behaviorists, they would basically say if you can control the consequences to somebody's behavior, you can control people's behavior, almost like we could be programmed. And what the Freudians were basically saying is that most of our problems that we have as an adult is probably rooted in our past, and we can't do anything about it, so it's in our past. And we might not even be aware of all the types of issues that we are having because that's in our unconscious. And there were some who could not stand that. That the two major movements in psychology at the time were the cold, calculating behaviorist and the cold and calculating Freudians. Okay, and so that caused humanist movement to develop, and that was with Abraham Maslow and Carl Rogers. So we have humanistic psychology, and we have their form of therapy called humanistic therapies. So in humanistic psychology, they emphasize human potential for growth, for self-actualization, for becoming the best version of yourself, reaching your fullest potential, and personal fulfillment. So with the humanistic therapy, they looked at the following. They were looking at how it is that people are successful. And that's one of the things that differed between Freud and Freudians and the humanistic individuals, is that they examined and researched people who were successful, who did not have issues in their life, okay, and wanted to find out what they were able to do and how they accomplished these tasks. And these are some of the ideas that led to their therapy. So humanistic therapy attempts to support personal growth by helping people gain self-awareness and self-acceptance. So by allowing people to really truly see who they are, what type of individual they truly are, and then by getting people to accept themselves, warts and all, good, bad, and ugly, to be accepted. It's not saying you don't want to change. You could change and become better, but they want you to accept where you are. So knowing who you are and then having some way to accept the self that you are. So that is the premise that we have with humanistic therapy. Another form of that would be client-centered therapy, which is Carl Rogers, named for his style of humanistic therapy. So when you think about humanistic therapy, if you go to a bookstore, if people still do that type of thing, you walk into a bookstore, you'll see self-improvement sections, and you will tend to see a lot of humanistic psychology in that section, because what that section is about, again, is going to be about human potential for growth, about becoming the best version of you that you possibly can. So these therapies, humanistic therapy and client-centered therapy, they are really about developing the person. Okay, so now let's compare real briefly here the therapies, the humanistic versus psychoanalytic therapies. They both seek to promote insight, okay? They're both looking to promote insight. So the goal of humanistic therapy is to promote growth. The goal of psychoanalytic psychotherapy is to cure a mental illness. So one is about growth and development, and one is about fixing something. Then how do they view how to improve? For humanistic psychotherapy, you take responsibility for feelings and actions except oneself. So again, this is that idea of accepting who you are. For psychoanalytic psychotherapy, you want to bring unconscious conflicts into conscious awareness. So you're shining a big light on some sort of conflict that you have in your unconscious once your therapists have been able to bring that out. What is the role of the therapist? In humanistic psychotherapy, the role of the therapist is to provide an environment in which growth can occur. The role of the therapist in psychoanalytic, provide interpretations of your dreams, resistance, and transference to point out why it is that you're having those dreams, why it is that you're experiencing that resistance, why it is that you're experiencing that transference. Again, with the idea of providing insight to the patient. What is the content of therapy in the humanistic perspective? The content of therapy is going to be your conscious feelings, your actual self, and your ideal self. Who you really are and what you would really like to be. And from the psychoanalytic perspective, trying to say what your unconscious conflicts are. And in humanistic psychotherapy, the focus of time is going to be on your present, where you are now, and your future. In psychoanalytic psychotherapy, the focus is going to be on one's past. So we see here that they are both looking to do and develop some sort of insight and promote insight for the patients, but they do have different ways of going about it. Now, the style of client-centered therapist. So we have the following. Carl Rogers is the promoter and founder of this view of therapy. He focused on things such as being non-directive. So in his therapy, he was not controlling the patient, okay? He was being genuine. He wasn't putting on a false front or a facade. He was being accepting and showing unconditional positive regard, not being all judgy and judgmental, and being very empathetic. So let's look at these. Being non-directive. Let insight and goals come from the client rather than dictating interpretations. So you are in charge in this form of therapy. It is truly client-centered. Being genuine. Be yourself and be truthful. Don't put on a therapist facade. So you're going to be you and true to you. So you're not going to have this sort of false front or playing a particular role as therapist. You're truly being as genuine as you can be in this therapist-client relationship. Being accepting and showing unconditional positive regard. Help the client learn to accept themselves despite any weaknesses and flaws they may have. And being empathetic. Demonstrate careful attention to clients' feelings, partly by reflecting what you hear the client saying. One of the key aspects of client-centered therapy is that what these therapists are trying to do is truly listen to the client, okay? And that's one of the key aspects. And how they show this empathy is through what they refer to as active listening. Active listening is when you truly hone in and pay attention to what someone is truly saying. And they have this in client-centered therapists, and they show that they are tuning in to clients' feelings and meanings, what they're saying, when they are doing active listening. So what happens is this. The client, and you can do this in active listening when you're talking to a friend, but the idea is that the person who's talking, they finish what they're saying. You didn't interrupt them. They finished whatever they wanted to say. And then what you do, who is active listening, you will summarize or paraphrase what they just communicated to you, trying to ensure that you understood. So your father wasn't around much. So they may have said a bunch of stuff, okay? But what you're trying to make sure of, are you understanding what they were saying? So you ask a question. You paraphrase in your own words what you think they just said. 2, you invite clarification and elaboration. So if they used a certain word or term, for example, when you say anxiety, what does that feel like to you? So what they're trying to do there is to make sure that your anxiety and their anxiety is the same anxiety. What is going on in your body and thought? So you're clarifying and getting information from them to make sure, again, you truly understand what they are saying. And then you reflect feelings. It seems like you are disappointed. Am I right? So you're asking, you're reflecting feelings to them. Okay. Now, one of the things too that we need to understand is this. Have you ever been in a conversation with somebody that you're really close to and they say something like this to you? Are you mad at me, or you feel hurt or something of that nature? And you don't, but they put and project onto you something that they think is going on. And usually that doesn't make you feel too good. So what active listening is also doing here is that you as the listener own your own feelings. And so you're asking them what their feelings are. Okay. So it seems like you're disappointed. Is that right? So you're not saying you are, you're asking them if they are. And so there's a big difference between that. Okay. So when it comes to client-centered therapies, there's some skills there like active listening, which people can be trained on, which is very, very powerful to truly listen to somebody. Because let's be honest, when you're having a conversation with somebody and it's a good conversation and they're saying things that you're truly interested in, at one point in the conversation, you're going to check out. The person's still talking, but you checked out mentally because you're already trying to prepare what you're going to say. So the next area that we want to talk about is behavior therapy. Behavior therapy. Sometimes insight is not helpful to recover from some mental health problems. Just having insight about it doesn't really do anything. So now that you know what the cause of the behavior is and all this type of stuff, it doesn't change the behavior itself. So the client might know the right changes to make, but finds that it's hard to change one's actual behavior. And that can happen quite a bit. Often that's true for most of us. We all know what we need to do in order to manage our weight. Okay. But that may require us to change or alter our behavior. And that may be problematical to us. Okay. It's hard for us to change our behavior. So behavior therapy uses the principles of learning, especially classical and operant conditioning, to help reduce unwanted behavior or unwanted responses. So those behaviors that you want to get rid of, we can use those things that we talked about in chapter 7 to try to figure out ways in which we can start to get rid of those bad behaviors, those behaviors that we don't want. These might include behaviors such as addictions or emotions such as panic, that we can sort of use behavioral techniques, principles of learning, in order to get rid of those types of bad behaviors. So, for example, using classical conditioning techniques, we can use something called counter conditioning. It refers to linking new positive responses to previously aversive stimuli. So if you have been conditioned to fear stores because you have panic attacks there, you could be led into a store and then help with relaxation exercises. So you're in a store and then they talk you through relaxation exercises. The goal is to start to associate stores with relaxation, which is going to be a state which is incompatible with fear. So stores have been associated with fear. You go into a store, you feel fear. But if you are taken into a store and you're taught these relaxation exercises, you can start to pull that store away from feelings of fear and associate that store with feelings of relaxation, because they're incompatible with it. You can't have both. So that is one technique that can be employed using this behavioral form of therapy. And some people really like behavioral therapy because it is very, very direct. You are addressing behaviors and you can do things, tried and true techniques, to try to change and alter those types of behaviors. Another form of therapy that can be used is exposure therapy. A conditioned fear can worsen when avoidance of the feared situation gets reinforced by quick reduction in anxiety. So if you have something that you really can't stand, let's say you don't like speaking in public, and every time the teacher calls on you in this rather large lecture hall and you start to have anxiety, someone else, you look at somebody else and somebody else blurts out the answer, for example, and distracts the teacher. That's avoidance. That doesn't help you. You get reinforced for reducing that anxiety all of a sudden, but the problem is the issue is still there and it becomes even more powerful. So you're still going to have a great deal of fear of speaking publicly. So guided exposure to a feared situation can reverse this reinforcement by waiting for the anxiety to subside during the exposure. One technique could be if you are afraid of, let's say, uh, a snake or snakes. And the idea is that you can just expose the individual. You're exposed to snakes, okay? And then you just reverse this reinforcement by waiting for the anxiety to subside during the exposure. So you're getting anxiety, the snake is there, and they're just going to wait you out. Exposure therapy, all right? So the person can habituate, that is, get used to the anxiety itself and then the fear situation. It's not really pleasant all the times, but that can work. You just are sort of like becoming inoculated to the fearful object in some way. So the idea is with exposure therapy, they simply expose you to the thing that you are fearful of. So there are a variety of techniques that employ behavioral conditioning in one way or another. One is systematic desensitization, where what they do is that they're trying to desensitize you to a fearful object, okay? And the idea is that they bring you to something, a picture of the fearful object, then they bring you a small mannequin figure of the fearful object, and they just get you closer and closer to the more fearful object. But each time they're sort of training you to control the fear, to become desensitized to it. Then there's aversive conditioning. When a person has been conditioned to have a positive association with a drug, for example, you drink alcohol, but you think you're drinking too much alcohol and you want to try to control that behavior, then you can employ aversive conditioning. They want to associate the drug with a negative response now. So there's a drug, for example, called antabuse, which is, if antabuse is in your system when you're drinking alcohol, it makes you want to throw up. It makes you nauseous, okay? And so what happens is this. They want to associate alcohol with nausea, okay? So first of all, the alcohol is first a neutral stimulus. It doesn't cause you to become nauseated once you drink it. But once you add the drug, the antabuse, okay, and you pair the alcohol with the antabuse together, and you have the nausea because of the drug, the bond will establish between the neutral stimulus, which is the alcohol, which then becomes a conditioned stimulus, so that when you drink alcohol now with no drug around whatsoever, it makes you nauseous. That is what aversive conditioning is. It's basically swap what you normally feel when you drink alcohol to this other feeling of nausea when you drink alcohol, which obviously, if you become nauseated, you're going to want to do less of the thing that causes you nausea. Believe it or not, there's a drug out there too that uses a similar technique for food. Okay, it's not exactly the same, but there's this drug that they tell you to take that makes you somewhat nauseous. Okay, they get you up to a certain level. And so when you eat and you're nauseous, will you eat more or eat less? I'll tell you, you will eat less. And therefore, they use that drug, believe it or not, for weight control management, because your appetite is being subtly suppressed because you have this slight nausea that's always present, and therefore your appetite is being suppressed, and that means ultimately you'll start to lose some weight. So there's a variety of techniques that can be employed using the things that we talked about in Chapter 7 on principles of learning. Couple more here. We have operant conditioning, the shaping of chosen behavior in response to the consequences of the behavior. Again, that's the key idea. We see that an organism behaves a certain way, and then there's going to be a consequence to that behavior. All right, so behavior modification refers to shaping a client's chosen behavior to look more like a desired behavior by making sure that the desired behaviors are rewarded, so you get reinforced for those, and problematic behaviors are not rewarded. So we don't reinforce the problematic behaviors, or we punish them so that behavior can be modified. And behavior modification is used quite a bit in therapeutic situations. There are whole sorts of mental institutions around that employ operant conditioning and behavior modification on the clients that are at their facilities, a whole area of expertise in that particular area. So we have what is known as applied behavioral analysis, or applied behavioral application, is used when with nonverbal children with autism, for example. It rewards behaviors such as sitting with someone making eye contact, and sometimes punishes self-harming behaviors. Now, the key thing here is this, is that we can't use talking therapies with people who are nonverbal. That means they're not able to communicate to us. So we have to employ other types of therapeutic approaches, and that's where behavioral therapy comes in, or operant conditioning therapy specifically, because it does not require the organism to be able to speak. It doesn't need it. I mean, for example, if you have somebody who bangs their head rhythmically and ritually on a wall, they could do certain types of things to try to stop that behavior. They could do a spray bottle to the face or an electric shock, which may be more aversive and cause them to stop that behavior. So the idea is that these techniques can be employed to modify the behavior of many nonverbal individuals. Also, we have this idea of token economy. Usually at an institute, let's say we have a bunch of clients that live at this particular facility, and if they don't have it, they'll implement a token economy. What that means is they want to be able to have something at that particular facility that people want to have because they can use them to do things, to buy video games or rent video games or do that or the other thing. And so in order to do that, they institute a token economy. It's like money. They can use coins or stars or whatever. And when you behave well and do your work, you are given tokens. When you misbehave, tokens are taken away from you. And when you want things extra, you can utilize tokens to buy those things. So again, what they're doing is they're instituting an economy within the facility that allows them, believe it or not, to control people's behavior. Now, psychology does many things, and the behaviorists particularly are very fond of saying one of the key things that we're trying to do in psychology is to predict and control behavior. And so in this instance, that's what token economies at these type of facilities do. It's the same thing that we have in societies. When you're speeding and you get a fine for $300 from the local government, that's going to hurt, and it may cause some changes in your behavior in the future. Okay, so the idea is that we're using these types of things, operant conditioning ideas, in order to modify people's behavior. So let's critique real quickly this idea of behavior therapy before we start getting close to the end here. Does it work? Well, when it does, do the changes stick without insights or other changes to hold the new behavior in place? So what it comes down to is that it does often work. Behavioral modification, behavior therapy does work, but extinguished behaviors and reactions do spontaneously reappear. So once you have been conditioned and the problematic behaviors go away, very much like we talked about in chapter 7, the possibility of spontaneous recovery is always there, okay, but it does work. To ensure maintenance of changes, a transition is needed from artificial rewards to awareness of natural environmental consequences. So what they want to do is try to get you to, you've heard the term of making a lifestyle change or something of that nature. They want you to try to integrate these changes into your life in such a way that there'll be other natural environmental consequences that will help you to maintain the new behaviors, so that they'll be reinforcing them, so you don't have the possibility of spontaneous recovery of previously bad behaviors. So it does work, but there's some maintenance involved in behavior therapy. Is it ethical? Since conditioning operates below conscious awareness, and that's why we bring this up. Remember, with behavioral conditioning, oftentimes it's not something that we're fully aware of. So we could have behavior modification going on, and you're not even aware that someone is modifying your behavior. So since conditioning operates below conscious awareness, couldn't people's choices and reactions be manipulated without their consent? To minimize ethical problems, that basically is a yes, it could. But to minimize these ethical problems, we need to acquire consent, at least from a guardian. So those nonverbal children that I referred to earlier, who live in facilities in which they're having behavioral modification done onto them, they have to have consent from their legal guardians or from their parents in order to do that. You just can't do it. It's not ethical. So acquire consent, at least of guardians, and develop goals for treatment that are more humane than the alternative. For example, if someone is banging their head up against a wall, that can cause some major issues. Even when you put a helmet on them, they're still banging their head up against the wall. You don't want to tie them up, and you don't want them to hurt themselves. A small electric shock or a mist in the face may be seen as a viable, more humane alternative from them causing a concussion, for example. So the idea here is that that's something that can be done and ethically seen as being very, very responsible. I'm going to pause there to see if there are any questions or clarifications about any of this I've just talked about. Some of it might be new to you. So I'll wait to see if anyone speaks up, or if you can send me a chat message. Okay. So what we've done now, we've talked about psychodynamic, psychoanalytic. We've talked about the humanistic therapies, and we've reviewed some of the basic ideas of the behavioral therapist, behavior therapy. Now let's look at another aspect of therapy, and that is cognitive. Cognitive therapies, okay, and this is how we think, okay, our cognition. Now, the theory behind cognitive therapies is very simple. For example, being depressed and or anxious involves negative thoughts and interpretations. So their belief is that when you have depression, it could be based on the way you think about things and how you interpret or attribute events or causes to events. So as an example, someone loses their job. One person that loses their job, they see the reason for their job loss is internal, and they think of things like this: I'm worthless, it's hopeless. Those types of negative or depressive explanatory decisions there, attributions, lead most likely to depression. Another individual who loses their job, their internal beliefs may be more of this nature: well, my boss is a jerk, I deserve something better. It's not focused on who or weaknesses of themselves, but on external factors. Someone who interprets that as being the cause for their loss of job most likely will not lead into depression. So in the cognitive perspective, the cause of depression are not bad events necessarily, but our thoughts about those events. Something happens. How you interpret that something that happens is going to be key. If you interpret it in a way that makes you feel small and insignificant and worthless, then depression is going to be a more likely outcome. If you interpret it in ways which does not make you feel that way, that gives causes that go beyond you and not necessarily tied to you personally, then most likely you will not wind up having depression as being part of your makeup. So that is the premise behind cognitive therapies. It's going to be how you think, okay, your patterns of thought. So cognitive therapies practices this: helps people alter the negative thinking that worsens depression and anxiety. That's what it comes to. Therapists might suggest other thoughts that clients could have about their lives, or at least point out when clients jump to conclusions that make them feel worse. So it's how you think about things which needs to be controlled to make sure that you optimize how you feel about yourself and to avoid some of the psychological issues that could result if you think too harshly about yourself. Some of the schools of cognitive therapy are here. We have Albert Ellis's rational and motive behavioral therapy. And here is challenging irrational beliefs and assumptions that people have. Aaron Beck's cognitive therapy for depression, correcting cognitive distortions, because sometimes people's thinking is way distorted. You blow things way out of proportion, for example. And Donald Mishenbaum's stress inoculation training, practicing healthier thinking before facing a stressor, disappointment, or frustration. So here, the idea is that you are practicing the way you want to think about something before you get into a situation that may be stress inducing. So you're trying to inoculate yourself before you get into those circumstances. So a variety of ways in which we can look at how cognitive therapy can be employed, but it all comes down to the same thing: helping people think less negatively about themselves that would worsen their depressions and anxiety that they may experience. So let's look real quickly here at some cognitive therapy techniques. So there's the aim of the technique and the technique. So we have one technique is to reveal beliefs. Question your interpretations. So here, you explore your beliefs, revealing faulty assumptions such as, I must be liked by everyone. So of course, if someone really believes they must be liked by everyone, they will always be sadly disappointed. You can't do that. The other idea is the following: rank thoughts and emotions. Gain perspective by ranking your thoughts and emotions from mildly to extremely upsetting. So now, not everything is going to be catastrophic. Okay, you're ranking them. Then we have the other technique of test beliefs. Examine consequences. Explore difficult situations, assessing possible consequences, and challenging faulty reasoning. Decatastrophize thinking. Work through the actual worst case scenarios or consequences of the situation you face. It is often not as bad as imagined. Then determine how to cope with the real situation you face. So the idea here, let me go back if I can. So with decatastrophizing thinking, you're basically coming up with the worst case consequence of something. Okay, what could you possibly face? And then you go through facing the thing that you were worried about, then determine how to cope with that real situation you face. Often it's not going to be as bad as you imagined it would be. Then you can also change beliefs, take appropriate responsibility, challenge total self-blame and negative thinking, noting aspects for which you may be truly responsible, as well as aspects that aren't your responsibility. Another thing too that we see a lot of people do is they take responsibility for things they had no possible ability to control whatsoever. Okay, and the problem is that you need to change your beliefs, and that's what the therapists are trying to do here. You need to change beliefs, take appropriate responsibility, and that's what people sometimes don't do. They take responsibility for things that they could not possibly control, and then resist extremes. Develop new ways of thinking and feeling to replace maladaptive habits. For example, change from thinking I am a total failure to I got a failing grade on that paper, and I can make these changes to succeed next time. So again, what we're seeing with these cognitive therapy techniques is trying to get control over how it is that the patient or the client is thinking about things in their life. Sometimes thinking is our worst case, it's our worst thing for us to do. In fact, oftentimes when you're having problems going to sleep at night, when you have a bout of insomnia, your head hits that pillow, and then you do the worst thing possible. You start thinking about problems that you experience, or worries and concerns that you're having, which cause you not be able to get to sleep. I want to ask you, if that happens to you, because I know it happens to everyone to some extent. So what we see here is a variety of types of therapies that we've looked at. Now, the last couple of slides I want to cover real quickly here is going to be looking at comparing modern psychotherapies: psychodynamic, client-centered, behavior, cognitive, cognitive behavioral, group and family. We did not cover cognitive behavioral here or group and family, but we'll just go over them real briefly at this time. So the presumed problem in psychodynamic psychotherapies is this: the unconscious conflicts from childhood experiences. Again, past focused. Client-centered therapy, the presumed problem: barriers to self-understanding and self-acceptance. Behavior therapy, the presumed problem: dysfunctional behaviors, problem behaviors. For cognitive therapy, the presumed problem: negative self-defeating thinking. Cognitive behavior, combination of the behavior and cognitive. With cognitive behavioral therapy, self-harmful thoughts and behaviors. And for group and family, stressful relationships, how it is that we interact with one another. The therapies aimed. In psychodynamic therapy, the aim is to reduce anxiety through self-insight. In client-centered therapy, the aim is to enable growth via unconditional positive regard, not being so judgmental or so judgy, being self-accepting, genuineness, being real, and empathy, really truly understanding the other people through making sure you understand their feelings and active listening and all that. The aim of behavioral therapy: relearn adaptive behaviors and extinguish problem ones. So learn good behaviors and get rid of problematic behaviors. The aim of cognitive therapy: to promote healthier thinking and self-talk. Don't downgrade yourself and talk negatively about yourself, but be more positive. Cognitive behavioral therapy's aim: promote healthier thinking and adaptive behaviors. And the aim of group and family therapy: to heal relationships. And then the therapy's techniques. With psychodynamic, one key technique is to interpret patients' memories and feelings. For client-centered therapy, to listen actively and reflect clients' feelings. With behavior therapy, using classical conditioning or operant conditioning to change one's behaviors. Cognitive therapy technique: train people to dispute negative thoughts and attributions. So when you have a negative thought, you're sort of trained to downplay that negative thought. Say, get away from me. Say, that's not right. What I just thought about myself is not proper. Cognitive behavioral therapy technique: train people to counter self-harmful thoughts and to act out their new ways of thinking. And then for group and family therapy technique: develop an understanding of family and other social systems, explore roles, and improve communication. For example, in families, sometimes we need to understand how families dynamics work, and that's one of the things that a family therapist can do, is to point out those roles and how people are feeling and the relationship dynamics there. So those are some of the modern psychotherapies and how we've compared them. Now, the last few things I want to cover first is going to be, this last slide here is going to be on the biomedical therapies. Can't leave without talking about them. And the biomedical therapies are interventions in the brain and body that can affect mood and behavior. So the ones that we've just finished talking about were considered the talk therapies. All they really did was talk. Talk, 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 the talking therapies. Now, the biomedical therapies bring in another aspect of it, and that's going to be how it is that we can impact the brain and body. All right. So with biomedical therapies, it refers to physically changing the brain's functioning by altering its chemistry with medications or affecting its circuitry with electrical or magnetic impulses or surgery. Then we have the psychopharmacological. Okay, psychopharmacology refers to the study of drug effects on behavior, mood, and the mind. So first, in chapter 2 of this textbook that we used here, we talked about the biological basis of behavior. Okay, and we introduced yourselves to ideas of neurotransmitters and things of that nature. And then when we got to, I believe it was chapter 3, consciousness in the two-track mind, we talked about drugs and how drugs will have an impact on our behavior, mood, and our mind. So we see these things sort of coming together here. We use certain types of drugs in order to combat certain types of issues. One drug that we know of would be SSRIs, selective serotonin reuptake inhibitors, that impact serotonin in the brain. So serotonin is going to be released, and then serotonin is going to be reabsorbed into the axons that release them. If you take something like Prozac, Prozac will block the reuptake of serotonin, allowing serotonin to be active in your brain for longer periods of time, and the person feels less depressed. That's the way it works. So with that, an SSRI being prescribed and someone going through some sort of talking therapy as well, the patient's symptoms may be reduced quite readily. And then we have psychosurgery. We have a lobotomy. A lobotomy destroys the connections between the frontal lobes and the rest of the brain. This decreases depression, but it also destroys initiative, judgment, and cognition. Okay, so the idea here is that it is a major thing to really give someone a lobotomy. And then there's microsurgery. It might work by disrupting problematic neural networks involved with aggression or obsessive compulsive disorder. Of course, we also talked about ECT, electroconvulsive therapy too, where we provide an electrical shock to the brain for patients who are severely depressed, and sometimes that brings them a little bit out of their depression. So real quickly here, I think there's a couple more things here that I do have here. How do we know if therapy works? Well, there are different measures of the value and effectiveness of psychotherapy. Whether the client is satisfied, whether the client senses improvement, whether the therapist sees some sort of improvement, and whether there has been an observable measured change in initial symptoms. So you gave them some sort of test at the beginning of therapy, and then a few months later, you can give them the same test later. Have the symptoms been reduced would be the key question there. So there are problems with some of these measures. If clients perceive an improvement, are they just trying to justify the time spent on therapy? If a therapist sees an improvement, are they just seeing only their good outcomes and forgetting about the bad outcomes? If research shows good outcomes for most clients, would they have improved anyway? One point is this: usually people who go through some sort of psychological issue, they tend to get better, okay? But we do know from a lot of research that they tend to get better without therapy sometimes, but with therapy, they get better sooner and they have fewer relapses. The people who did not go through therapy, they tend to get better to some extent, but they tend to also have relapses. They get back to the depressions again, or whatever the case may be, whatever the issue is. So we do see that overall the research out there says someone who's having some sort of mental issues, it is good to seek help from somebody. So studying treatment outcomes. To track the effectiveness of an intervention, we use things like a control group not receiving the intervention or even a placebo group. These are some of the ideas and things that we talked about in the very first part of the course in chapter 1 when we had that section on research design and experimentation. Okay, these things are done now in order to see if treatments actually do work. We spend lots of money on drugs and going to therapists. We want to see if they actually do work. And so people will study treatment outcomes in order to determine this by designing experimental controls, control groups, an experimental group. One group gets the treatment, one group doesn't get the treatment, and then comparing them later and seeing if the group that went through the treatment or received the drug, are they better off than people who didn't? So to measure effectiveness, we use objective, observable measures of symptoms rather than relying on client or therapist perception. So the things at the top part of this slide, they're good. That gives us some perceptions of what people think is going on, but we're more interested in the things at the bottom of this slide by having something that's observable and objective that we can really focus on. Okay, before I go to the next slide, are there any questions about the content that we've covered so far today? Then I'll go over some reminders and some announcements. That is a no. Okay, so let's go ahead and finish up here. So questions and answers and comments. Okay, first, a couple of announcements. We have, I believe, according to my recollection here, one more lecture and check-in. The topics will be on Appendix B, which I believe is going to be on applied psychology or work psychology, and key items from the course. I'll be covering some of those next week as well. There is a required final exam, which will be Unit 6 exam, which I basically stated before, will cover chapters 15 and Appendix B primarily, but it will have items from previous chapters as well. Okay. And also, you should have noticed that I did grade the papers that I had available to me. So grades for your current event papers are there. I think I was, for the most part, okay with the results of them. I think the average is around a high B or low A, I think. And I put as much comments as I could on them. But I will post a recorded session about papers real soon, just to go over some of the things I want to make sure that you understand about why we use certain type of formatting in the American Psychological Association style and formatting guidelines, and going over some of the things I thought were somewhat problematic in some of the papers that I was able to read and grade. And also, I want to also announce that there will be some extra credit assignments that I'll make available to you next day or so, and they will be totally optional for you. All right, so you are required to take the final exam, but I'll make available to you some optional activities, and I'll describe them a little bit more once they are posted for you. And again, when I say optional, what I mean is you can take them, they won't count against you, they can help you. Okay, so I don't know if you'll be able to do all of them. I'll see when I put this together, but a course puzzle activity, which will cover the whole course, that may be somewhat lengthy, but again, there you go. And then there's an optional bonus comprehensive test. It'll be like 30 items or so that will be used as well. And then there's something too that I may want all of you to take, but I'll see. It's an optional APA assessment quiz. And basically, it's going to be based to some degree on the papers that you guys wrote, to just remind you of some of the American Psychological Association guidelines and why they may be important and why we did them. It'll be good to go over some of the in-text citation ideas and those types of things. Now, if you're in psychology, this will be of extreme help to you. If not, it will be of some benefit, at least by way of getting some points there. Okay, so that's all I wanted to talk with you about today. Are there any other questions or comments or clarifications required now that I've given you this additional information? Speak up or send me a chat message. I hope you guys are still there and I haven't lectured to an empty classroom for like the last hour or so. Okay, I'm going to believe that you're still there. Can somebody say hi to me? Hello?
Hi.
Thank you.
Hi.
Oh, you are there.
Hi.
Okay, I was concerned there. I said, man, no question. Usually I get some sort of chat. Maybe you guys are too tired from looking at election results. Who knows? Well, anyway, that's all I want to cover for you today. I'll keep you posted on those optional assignments and extra credit assignments a little bit later. Look for the recorded sessions on papers. They'll be good to look at if you decide to take the AP assessment quiz. If there's nothing else, you guys have a great weekend. I'll talk to you guys later. Bye.
Thank
Bye.
you,
Thank
and you
you.
too.
Bye.